So let's begin with a case scenario. A 42-year-old female is scheduled for a laparoscopic cholecystectomy. A BMI of 26, has mild asthma, uses salbutamol occasionally. It's an uneventful induction. She's intubated and ventilated and remains stable for the first 30 minutes. Thereafter, her blood pressure suddenly falls. On examination, she has a bilateral good equal air entry, pale and cool with a weakly palpable pulse. So what should you do? What is your differential diagnosis? And what clinical signs would you expect to see for each possible cause? This is what we'll be covering throughout the lecture. This was just a case scenario. Now compare this with another case scenario. There is a 75-year-old man has an extensive cardiac history, posted for hemicolectomy with anastomosis. During induction, the patient became hypotensive. The mean arterial pressure ranged from 55 to 60. This lasted for approximately 10 minutes, and after several boluses of phenylephrine, the mean arterial pressure increased to 65 millimeter mercury and stabilized. So these are two different contrasting case scenarios you all have seen. One is a young female, hardly any comorbidities except a mild asthma, who's become hypotensive. And this is a 75-year-old man with an extensive cardiac history. So I'll take you through both of this. So what is intraoperative hypotension? It is basically either you define it as in terms of absolute blood pressure or relative threshold as a decrease from baseline. So the frequently used definitions are a systolic arterial pressure below 80 millimeter mercury, a decrease in systolic arterial pressure of more than 20% below baseline, and a combination of definitions where either your systolic BP is below 100 and there is a 30% below baseline. But most commonly used definition is this: a mean arterial pressure less than 65 millimeter mercury is frequently used to define intraoperative hypotension. And this is what we are going to carry through throughout the lecture. We'll be talking in terms of mean arterial pressure. So what kind of hypotensions are we looking at? There is a post-induction pre-incision hypotension, that is even before the first surgical incision has occurred. There is intraoperative and there is a postoperative. So in your second case scenario, it was a post-induction pre-incision. And in your first case scenario of the lap cholecystectomy, there was an intraoperative hypotension. So why is intraoperative hypotension such a big problem? Why are we having a lecture? Why are we discussing all this? So it is said in a large observational study which had 1 lakh odd patients undergoing a non-cardiac surgery, increased durations of intraoperative hypotension was strongly associated with a 30-day mortality. So basically now we have moved ahead from anesthesia where we safely shift the patient to the CCU or the HDU and then shift the patient to ward. Now everything we are gauging in terms of 30 days morbidity and mortality, so to say at least, followed by 6 months and 1 year. So the point to drive here is that even short periods of post-induction hypotension, what happened in the second case scenario, is associated with a post-operative acute kidney injury. Now I'm continuing with the second case scenario of the 75-year-old patient. He remained stable until 2 hours into surgery, after which the systolic blood pressure fell steadily. So they gave phenylephrine post-induction. For 10 minutes, it remained like that. The MAP came okay. Then he was stable for 2 hours into surgery. After that, again, the blood pressure started falling. So surgeon attributed to a highly vascular tumor. MAP was 55 to 60 for nearly 5 minutes. And surgeon predicted that the blood pressure will improve in the next 10 minutes as he's addressing the bleeding. But the point for us over here is, does this duration of hypotension matter? Some say 5 minutes, surgeon is saying 10 minutes. How much are we going to wait? So now this is another study which has been published in Anesthesiology 21, where it is said that when the pressure is less than 70 millimeter mercury for 10 minutes, the risk of end organ injury is there. It further increases when your MAP is in the range of 60 to 65 for 5 minutes. And further, the risk of end organ injury is when even for 1 minute, your MAP is 50 to 55. So this study summarized that when your mean arterial pressure falls less than 30% from the baseline, there is a risk of acute kidney injury and myocardial injury in a non-cardiac surgery. So what is myocardial injury in a non-cardiac surgery? You don't have ECG changes. You do not have myocardial infarction. only your troponin levels are raised. So that is called myocardial injury. And they say that 90% of the cases of myocardial injury are non-ischemia, non-infarct, but there is definitely a myocardial injury which can lead to a 30-day morbidity and mortality. So similarly, if the fall in MAP is less than 20% from baseline, then the risk of MINS increases. Even for 1 minute, less than 50% of the baseline, the risk of MINS is very high. Okay, and even for in more than 50% for 5 minutes, the risk of kidney injury is very high. Okay, so basically we are mainly talking of end organ injury in terms of myocardial injury after non-cardiac surgery and acute kidney injury. Then there are other things also which are implicated with a post-operative outcome in intraoperative hypotension, myocardial infarction. But again, as I told you, your MINS, that is injury after non-cardiac surgery, is at a higher incidence. Acute kidney injury, as I told you before, morbidity, mortality. There is congestive cardiac failure. There can be stroke, cognitive decline, and delirium. So even if your mean arterial pressure falls for 10 minutes, everything may be perfect, but this patient is going to be probably delirious or have a cognitive decline, which we may not be able to pick up. We may never even realize that we have not addressed the blood pressure, and this is why something like this has happened. If there is a transplant, then poor kidney and liver graft function, and even if there is an anastomosis, like an esophageal anastomosis or a Whipple surgery, then there could be a post-anastomotic leak just because we have not addressed the intraoperative hypotension. Okay, so that's why it is strongly implicated to post-op outcome, and we have to be careful. Now with that, I'll come to a brief physiology of the blood pressure. So we are going back to our first MBBS days, where the systolic blood pressure, the determinant is a stroke volume, heart rate, vascular resistance, and the aortic distensibility. It reflects basically the left ventricular wall tension. I'll just rush through this. Pulse pressure depends upon your systolic and the diastolic blood pressure, and it reflects the stroke volume. Mean arterial pressure obviously is dependent by the systolic and the diastolic blood pressure, and it is the inflow pressure to most of the organs. This is the most important thing in this lecture. And diastolic blood pressure is only dependent on the systemic vascular resistance. It is the pressure which the left ventricle has to overcome. Okay, so this is our blood pressure. Now, what is mean arterial pressure? It is a product of the cardiac output and the vascular resistance. Cardiac output itself is a product of heart rate and stroke volume. So, your stroke volume is dependent on your preload, that is your venous return, your myocardial contractility, how well the heart contracts, and afterload, that is your against what force the ventricle has to contract. So this is how your stroke volume is dependent on. And your systemic vascular resistance, it depends upon your vascular radius, vascular length, and the blood viscosity. Okay. So now it is easy to predict that any fall in the mean arterial pressure will be a fall from the cardiac output or fall from the SVR. Now, fall from the cardiac output means fall from the stroke volume and fall from the heart rate. So bradycardia and lower stroke volume. So with that, let's go through the causes.